Welcome doctors, Dr. Naveen here. So today's webinar topic is neural tube defects. So in this topic, I'll be teaching you about the development of neural tube, followed by the clinical aspects of, that is the clinical features and the management of neural tube defects. At the end, I'll also give you an insight into the preventive aspects of neural tube defects. So let us begin the session now. Neural tube develops from, the process is known as neurulation process. So what is neurulation? Neurulation is the process of development of neural tube. How this process occurs? As we all know, the embryonic disc is made up of epidermis, we have a mesoderm, and we have an endoderm. So the three layers of embryonic disc are epiderm, mesoderm and endoderm. In middle of the mesoderm, there is an ectodermal proliferation known as notochord. So notochord degenerates in an adult, and the remnant of notochord in the adults is nucleus pulposus. So most of the notochord degenerates, but the nucleus pulposus is the part of notochord which is present in adult. And there is, let's go to the second step, the ectodermal thickening develops in the middle just above the notochord. So this is the ectodermal thickening, and this thickening is known as neural plate. So the neural plate is an ectodermal thickening just above the notochord in the middle of the ectoderm. And this ectodermal thickening helps in the formation of future nervous system, that is brain and spinal cord. So the brain and spinal cord develops from this neural plate. The neural plate during further development undergoes invagination. So the invagination of the neural plate now leads to formation of neural groove. There is an interesting clinical point here. The tips of the neural groove, they give rise to future neural crest cells. So what sites of neural crest? Neural crest origin from the tips of the neural groove. So this neural groove during the development, it fuses into a tube, and this tube gets pinched off from the ectoderm, and this tube is now known as neural tube. So the neural tube now is pinched off from the ectoderm, and it just lies above the notochord. This neural tube fusion starts in the middle. So it starts in the middle and it moves in a cephalocaudal direction. So if this is the middle of the tube, it moves from the middle to both the cranium side and the caudal side. The same neural tube, so let's picturize it in a vertical position. So this is the neural tube. There is a bulging of the neural tube at the cranial end. So this bulging later forms the brain of central nervous system, whereas the caudal portion lying outside is the spinal cord part. So here, along with the development of both the neural tube, there is also the development of skull and vertebral canal. Both the neural tube development and the skull and vertebral canal development, they occurs in tandem. Okay, so both are developing together. Now what happens? The neural tube during the fusion, so this is how the fusion is occurring, but what happens is there is an opening in the anterior part and the posterior aspect. So these openings are known as neuropores. So these openings are known as neuropores, anterior neuropore and posterior neuropore. Here the fusion of the neural tube is starting in the middle, it is progressing towards the cranium and the caudal region. This fusion gets delayed in the anterior aspect and the posterior aspect. So this neuropore, they later fuse. But what happens in few cases, in few children, there is failure of fusion of these neuropores. So there is failure of fusion of these neuropores, and this leads to development of neural tube defect. So now if you understand the development of neural tube and the fusion of the neuropores, then it is easy to understand the pathophysiology behind the development of neural tube defects. So let us now write down the ages, the developmental ages of different events in formation of neural tube. So this is the time period, and this is the part of, that is the embryonic part. So first is formation of neural tube occurs during the third week. Formation of the neural tube occurs during the third week. Then fusion of the neural tube begins at the beginning of the fourth week. This is followed by fusion of anterior neuropore. So when does anterior neuropore fuses? It fuses at the middle of the fourth week, that is 25th day. And 27th day is the fusion of posterior neuropore. So the posterior neuropore fusion occurs during the 27th day. So after understanding the development of the neural tube, let us start the clinical aspects of the neural tube. So the neural tube defects, as I already told you, the neural tube defects, they develop due to improper fusion of the neural tube, and there are different varieties of the neural tube. Before going into the details, let us understand the etiological aspects. Okay, so when it comes to etiology, it is the most common structural congenital anomaly. So neural tube defects are the most common structural congenital anomalies in children. When it comes to incidence, it is seen 1.5 per children. Okay, 1.5 per 1000 children. This is the incidence of neural tube defects. The maternal factors which lead to development of neural tube defects are: first is alcohol, second is nutritional deficiencies, that is the maternal malnutrition is the most common etiological factor. When I say maternal malnutrition, most important is folic acid. Along with folic acid, you need to remember one more mineral which is implicated in causation of neural tube defects, that is zinc. So this is the reason we give periconceptional folic acid supplementation to the expectant mothers. And there are a few more etiological aspects, right? And one is diabetes in mother. Okay, insulin dependent diabetes mellitus in mother is also a causative factor. One more important thing take home is anti-epileptic drugs. Okay, usage of anti-epileptic drugs like phenytoin, carbamazepine may lead to neural tube defects in the children. Okay, they are a kind of teratogens. And the next etiological point is radiation exposure during pregnancy. So most of the times in the pregnancy we do non-radiational procedures like ultrasound and MRIs. X-rays and CTs are contraindicated because they may become a teratogens leading to the congenital anomalies, and the radiation exposure can lead to neural tube defects. So these are the maternal factors. So now the clinical features of neural tube defects. Let us there is a spectrum actually. Just remember this. When I say neural tube defects, there are two pathophysiological aspects here. One is failure of neural tube fusion. So I am directly relating to the neural tube. But this neural tube, surrounding the neural tube, there is parallel development of the skull in brain region, and there is also a development of vertebral arches in the caudal region around the spinal cord. So this is the skull, and these are the vertebral arches which are developing around the spinal cord. Now what happens? There are two entities here. One is failure to fusion of brain and spinal cord, and the second entity is failure of proper formation of skull and the vertebral canal, leading to their defects of covering. So first spectrum of neural tube defect is anencephaly. So this is frequently asked in the exams. Anencephaly is failure of fusion of anterior neuropore. So by this time you know what is anterior neuropore. Failure of fusion of anterior neuropore plus failure of proper skull development. So there is a defect in the skull. Because of the defect in the skull, the whole of the brain tissue, it herniates from the skull, leading to degenerated brain tissue appearing outside of the child. So this is a very serious condition, anencephaly, and most of the times there is stillbirth or intrauterine death in most severe forms. Even in milder forms, what happens? The patient may have neurological disabilities, right? The patient may have neurological disabilities, and there is psychosocial maladjustments. So what is the outcome? Most of the times, anencephaly is a life-threatening condition leading to either intrauterine death or stillbirth. But in some cases, in milder cases, even though there is birth, even though there is live birth, the child may have neurological disabilities and psychosocial impairments or psychosocial adjustments. In anencephaly, the vault of the skull is absent. So how to identify the spotter of anencephaly? Sometimes they give spotter in the exam. So the vault of the skull is absent. So let me brief you the facial features of anencephaly too. So what are the facial features of anencephaly? The child has the prominent eye bulging, there is absent the neck. So because of the absence of the neck, there is continuation of the mandible with the thorax. So there is a continuum of mandible or jaw with the thorax due to the absence of neck. And you can identify pregnant females. So there may be a suspicion of neural tube defects if the pregnant female comes with the complaints of hydramnios. Hydramnios, otherwise known as polyhydramnios. What happens here? There is excess of amniotic fluid. Why hydramnios is seen in anencephaly? Because of degenerated brain, the sucking reflex does not develop properly. So there is improper development of the sucking reflex. So what happens now? The fetus cannot drink the amniotic fluid. So whole of the excess amniotic fluid, it gets collected in the womb, leading to polyhydramnios. So after anencephaly, you need to understand the basic differences between what is a meningocele, what is meningoencephalocele, and the third entity is meningohydroencephalocele. So when I say anencephaly, you clearly know that it is both maldevelopment of skull and also improper fusion of the neural pore. But there are three other entities known as meningocele, meningoencephalocele, and meningohydroencephalocele. Here I am only talking about improper development of the skull. So the skull bone is not properly formed. Because of improper skull bone, there is herniation of meninges here. So what are meninges? Meninges are covering of the brain. So in meningocele, you will see only a part of meninges herniating through the skull bone. In meningoencephalocele, along with the meninges, there is also herniation of brain tissue. So there is also a brain tissue herniation here. The third entity known as meningohydroencephalocele. Yes, there are both meninges plus brain tissue associated with ventricular cavity herniation. So the ventricular cavity also herniates in meningohydroencephalocele. So as we move from the left corner of the screen to the right, the severity of the disease increases. So the severity of the disease increases starting from meningocele, then meningoencephalocele is still severe, meningohydroencephalocele is further still severe when it compares to the spectrum of neural tube defects. Now, the first entity what we discussed is problem with anterior neuropore. So most of the times we are talking about the maldevelopment of the brain tissue and the skull. Now, the second entity is spina bifida. So spina bifida, the name itself says the spinal cord has bidivisions, that is the double division. So now you see it has two divisions again. Spina bifida occurs both in severe form and also the milder form. So there are two forms when it comes to severity. One is very severe, the other is milder form. The milder form is, it is spina bifida occulta. So this is milder form. The severe form is spina bifida aperta. So let us start discussing the milder form. So in the milder form what happens? There is proper fusion of caudal neuropore. So there is no problem with the caudal neuropore. It is fused. It is all right. But there is improper fusion of vertebral arches. Vertebral arches, there is non-fusion. But this non-fusion is mild, and in most of the cases, even though the vertebral arch is not fused properly, the spinal cord or meninges covering the spinal cord still, they do not herniate here. So there is no question of herniation. In spina bifida occulta what happens? Only there is defective fusion of vertebral arches. There is no herniation at all. So next condition, so as I already told you, it is a mild asymptomatic form, right? It is a mild asymptomatic form with no symptoms. But how to identify this child? So there is a tuft of hair on swelling present on lumbosacral region. So if there is a child, newborn child with a small swelling in the lumbosacral region and the covering of the skin is with tuft of hair, then it is a clear-cut diagnosis of spina bifida occulta. So let's now go into the severe forms. In spina bifida aperta, one is meningocele. So there is some aperture. Aperta means aperture. So meningocele means the meninges of the spinal cord. Meninges of spinal cord are herniating here. So there is herniation of the meninges of the spinal cord. In second variety known as meningomyelocele. So this is the term you frequently hear when I say neural tube defect, because this is among the neural tube defects, it is most common. What happens in meningomyelocele? There is defective fusion of the vertebral arches. Along with that, there is herniation of meninges plus spinal cord. Along with the spinal cord tissue, there is also a herniation of the spinal nerve roots. So here, the spinal nerve roots are getting compromised and the child may present with symptoms. So what are the clinical features of meningomyelocele? The child can have flaccid areflexia and paraplegia. The child has the weakness of the limbs here, Sometimes even the sensory system gets affected. So there are sensory deficits. As I told you, because of opening of spinal cord tissue to the outside environment, the exposed tissue, it degenerates. So whenever there is degeneration of the spinal cord, severity is high, and the child may also have the problems with urinary and fecal incontinence. So this is the issue with meningomyelocele. These are the clinical features. So there is one more point to be added here. What happens because of the bulging of the meningomyelocele? Sometimes there is herniation of both medulla oblongata, and we also have the herniation of tonsils of cerebellum. So what are the two entities? Because of meningomyelocele, sometimes there is herniation of meningo oblongata and tonsils of cerebellum. This leads to a malformation known as Arnold-Chiari malformation. So this herniation leads to compression of ventricular cavities. Ventricular cavities, when they compress, they contain CSF, right? So whenever the cavity is compressed, the CSF cannot flow. Whole of the CSF, it accumulates in the brain, and this leads to a clinical entity known as hydrocephalus. So whenever you see a child with the problem of meningomyelocele, kindly look for hydrocephalus too, because sometimes meningomyelocele is associated with Arnold-Chiari malformation type 2. This leads to development of hydrocephalus. These are the two severe forms. There is the most severe form which is lethal is rachis. So what is this entity? Most severe form, also known as rachis. In the rachis, there is incomplete fusion of the caudal neuropore. As I told you, there is both anterior and posterior, or otherwise known as caudal neuropore. Because of the fusion, whole of the spinal cord tissue lies outside. So this is the most severe form known as rachis. So now you know the spectrum of neural tube defects. Let us now try to have an insight into how to diagnose neural tube defects in prenatal period. That is the prenatal diagnosis of neural tube defects. What happens here? There are three diagnostic tests. One is estimation of alpha fetoprotein levels. The second is estimation of acetylcholinesterase levels, and third thing is ultrasound. So what are the three entities? You may either estimate alpha fetoprotein or acetylcholinesterase levels, or do a prenatal ultrasound. Which is more accurate? Let us first write down the accuracy and which is most specific. So when it comes to accuracy, the AFP estimation, the alpha fetoprotein estimation, can be done in two periods. One is from the maternal serum. So we got two samples. One is maternal serum, the sample can be taken, and this sample is usually taken during 15th to 16th week of intrauterine period, whereas the other sample is amniocentesis, that is the amniotic fluid of baby is taken, and this sample is usually taken in between 8 to 10 weeks. The most specific is amniotic fluid. This is the most specific. You will get specific results when you take amniotic fluid. Whereas when it comes to accuracy, the maternal serum sample estimation has only 50 to 70% accuracy. So even though the maternal serum sample is easy to take, even though it is easy to estimate alpha fetoprotein levels in maternal serum, but the basic problem is the test results are not accurate. So there are many conditions in which maternal serum AFP samples are elevated. So the levels are elevated in other conditions too. If you want to specifically diagnose neural tube defects, you have to take amniotic fluid sample. So this sample is taken usually during 8 to 10 weeks. Along with that, the acetylcholinesterase levels can also be estimated in amniotic fluid. Okay, so the accuracy part, maternal serum is 50 to 70%, whereas amniocentesis it is 97%. When it comes to amniotic fluid acetylcholinesterase estimation, it is also 97% accurately it gives results of neural tube defects. But the gold standard for diagnosing neural tube defect, this is commonly done in clinical practice, is ultrasound, and the ultrasound gives 100% accurate results in estimation of the neural tube defects. So now we are left with two parts. One is the management, that is the treatment aspect of neural tube defect, and we will conclude the session by learning about the preventive aspects. So let us write down the treatment and prevention. So what is the treatment of neural tube? There is no cure for neural tube defects, right? We only need to treat. In milder forms like the spina bifida occulta, we need not do anything. There is only a symptomatic treatment. But in severe forms, what happens? We need to follow a multidisciplinary approach. So if there is a child with neural tube defects, there is involvement of a neurologist, an orthopedician, a physiotherapist, a psychiatrist, and a neurosurgeon. So there are many team of doctors who should be treating this patient. And along with that, the most important aspect of treating neural tube defects is parent counseling. Because it is very tough on the parent's part. The child is now having neural tube defects, the prognosis is grave. So the parental counseling plays an important role in managing neural tube defects. Okay, so the parent counseling is very important. We give rehabilitation service, we give social services, but most important for exam is surgery. So let us assume there is a child or there is an infant with neural tube defect. What is the optimum time to do a surgery? If it is an open defect, whatever may be, the surgery may be just closure of the skin or closure of the neuropore or closure of the CSF leakage. So any surgery, or sometimes it is also ventriculoperitoneal shunt. If the child is having hydrocephalus, we have to put a shunt to drain the excess CSF into the peritoneal cavity. So all these surgeries can be taken within 24 hours if the defect is open. When I said the open defect, it is meningocele or meningoencephalocele or meningomyelocele. In all these cases, this defect should be closed within 24 hours. Why early? Because there are high chances of contracting infections if the surgery is delayed. But when it comes to closed defect, we can wait till 48 hours. So only one extra day is allowed. Though because it is a closed defect, there are less chances of development. But if you treat it early, if you close the defect early, there are less chances of degeneration of the neural tissue. So always the surgery should be, your take home is the surgery should be done within 2 days of birth. But as I already told you, the neural tube defects have a grave prognosis. Okay, a neurosurgeon cannot go and start treating each and every patient. He cannot perform surgeries on all the people or all the infants with neural tube defects, right? There should be a criteria whether to operate a child or not to operate a child, and this criteria is known as, so the criteria which tells you whether to operate a child or withhold the surgery is known as Lorber's criteria of surgical management in neural tube defects. So what is Lorber's criteria? It will tell you whether to operate or stop operating. So when there is, let us say there is a child with paraplegia. There is a child with paraplegia which is very severe. There is a child, the second entity is, there is a child with kyphosis and scoliosis. There is a child with kyphosis and scoliosis. Third thing, there is a child with infection, that is ventriculitis. And the fourth entity is if there is gross hydrocephalus. And if the child is having any other associated congenital anomalies. In all these 5 scenarios, it is better to withhold surgery. The reason is there is 90% chances of death within 1 week of birth. So Yes, there is a child with neural tube defect. There is an open defect, and if the neurosurgeon wants to do a surgery, before undertaking the surgical process, first we should go across the Lorber's criteria. It says whenever these 5 features, that is the paraplegia, kyphoscoliosis, infection of the ventricles, gross hydrocephalus, or any other associated congenital malformation, when these 5 entities are present, it is always better to withhold the surgery, because within a 1 week period of birth, there are high chances of mortality. 90% of the child they die within 1 week of duration. So this is Lorber's criteria. So let us now conclude the session by learning about the preventive aspects of neural tube defects. This is commonly asked in the exams, so kindly concentrate here. So the prevention is by, as I already told you, alcohol, radiation, and alcohol radiation, the maternal alcohol intake should be curbed when there is chances of pregnancy, and radiation exposure should be prevented. But most important is, just remember the single word, periconceptional folic acid supplementation. What is the importance of this term? Whenever an expectant mother is given folic acid supplementation at the time of conception, at the time of pregnancy, there are chances of 70% reduction in NTD. Actually, this is a huge difference, right? If you give folic acid supplementation to an expectant mother, it is reducing chances of getting NTD by 70%. So this is commonly practiced across the world. So what is the dosage and duration? Let us discuss. So when it comes to dosage has 2 entities here: primary prevention and secondary prevention. What is the difference between a primary prevention and a secondary prevention? Primary means there is no history of neural tube defects in the family, or this is the first pregnancy, or if the previous pregnancy is uneventful. In all these situations, the pregnancy should be, there is a supplementation of folic acid, and the dosage is 0.4 milligram per day. So what is the dosage for primary prevention? It is 0.4 milligram per day. What is secondary prevention? Secondary prevention is there is actually a history of neural tube defects. So there is a history of neural tube defect. When I say history of neural tube defect, if there is one child with neural tube defect, the recurrent risk is, so the chances are recurrent risk is 3.5%. This is very huge. So there are 3.5% more chances of developing neural tube defect in the next child. If there are 2 child in the family affected, the risk goes to 10%. And if the 3 child are getting affected with neural tube defect, the risk for the 4th child is 25%. So in these scenarios, if there is chances of recurrent risk, the dosage will go up to 5 milligram per day. So what is the dosage for primary prevention? It is 0.4 milligram per day, whereas for secondary prevention, the dosage is 5 milligram per day. And what is the duration of the dosage? The duration is 2 months before conception and 3 months after conception. So the whole period is, we have to give it for 5 months, and you have to space it like this: 2 months before conception and 3 months after conception. So this is about neural tube defects. So we have started with development of the neural tube, then we went into understanding the clinical spectrum of the neural tube, followed by how to diagnose this neural tube and the management aspect. You need to remember the preventive aspects of the neural tube defect too. So thank you so much, doctors. So we'll be coming up with few more webinars on a weekly basis. So if you want to comment anything, you can type in the comment section and also in the Instagram. So if you want us to teach any future topics, any clinical topics, you can type in the message box too. Okay. Thank you. Then we'll conclude it here.